If you've been in a class with me or you've heard one of my lectures, you know how crucial documentation is. If you did not document it, you did not do it. Documentation is a legal document. If it is in there, it happened. So make sure that we're documenting. However, that being said, do not falsify documentation just to cover your ass in case something happens later down. So, nursing documentation is crucial. It's a legal record and it effectively communicates between other healthcare providers. If you're not there and somebody needs to know what happened, they need to be able to look at your note and see what happened. This is why my narrative notes personally are a little bit longer than other people's narrative notes because I will walk through the entirety of what happened. When you read my narrative notes from when I was working in hospice, you will understand everything that happened from the minute I walked in the door to the minute I left. And that is super important when it comes to the legalities of things. If somebody were to come back and sue, you can look at my note and know exactly what happened. So electronic health records, those are those comprehensive digital records. They're centralized. Patients in Rochester at least have access to their charts and can read their notes, which is why it's essential that we document in plain speak so the patients don't get confused and understand what's going on with their own health care. They're essential for reimbursement and being able to get that data quickly and easily. And then they improve care decisions, enhance patient safety, and boost overall efficiency because we can simply just search for a note instead of having to go digging through a chart. So, the evolution in the 1960s, this is the first time that electronic health records started. In the 1970s, the federal government began using electronic health records in VA hospitals. Um, So that was before most people had a computer in their home. The VA was digitalizing medical care. In the 1980s, started using EHRs more often. Electronics were becoming more available and we were getting more computers. It became more and more widespread. However, it wasn't until 1997 that the Institute of Medicine implemented a recommendation for nationwide EHR adoption to enhance the safety of our patients. And now there's not a lot of places you can go where there's not a digital health record. There's different digital formats for documentation. They're source oriented. That's your traditional discipline specific. It's going to say who said, like, this is a cardiology note, this is a neurology note. There's problem oriented medical records. They are organized around the patient's problem. So instead of focusing on all the ways that the patient's healthy, we are solely focusing on what's wrong. There's the PIE model. It focuses on problems, interventions, and evaluations. Again, focuses on what's wrong, not what's right. Focus charting, specific problems using data, action, and response. Very similar to pie charting, just with a different name. And then charting by exception is where we document only unusual and unexpected findings. Those are where you're taking the click boxes and you're going, okay, nothing unusual in cardiac. They had some crackles in their lungs. Nothing unusual, nothing unusual, nothing unusual. And it tends to take less time to chart by exception because you're only charting the things that are wrong. As I harp on all the time, nursing documentation is essential that it is accurate. It can improve patient outcomes. It ensures we're giving safe care. It gives accountability for the nursing care. If if you did it, you need to take accountability for it and you deserve credit for it. Put it in the chart. It makes it so that interprofessional health team members can communicate without having to find each other. It serves as a legal record. These things are held onto forever. So if you were to get called in 5 years for a lawsuit against a physician you worked with and you didn't document well enough, you're going to have a hard time recalling. You're never going to get called tomorrow for something you did today. You're going to get called in 5 years for the thing you did today. So you better hope that your documentation holds up. And it needs to be reliable, precise, timely, and comprehensive so that we can ensure that everything we need is there. Shared responsibility. Everybody has a role in documentation, assistive personnel included. They need to document the things that they do. You're responsible for documenting the things you did and following up on anything you delegate and making sure it's either documented or you're documenting that it was done after confirmation that it was done. Essential components, we have to have the patient demographics, vital signs, complete medical history. We need to know their medications, allergies, immunizations, any results from their labs, and then diagnoses, treatments, and anything else that's pertinent to their health. All of that information can easily be found within an electronic health record. To ensure that we're consistent, we're going to use the FACT principles. F is for factual. This is concrete, objective, descriptive information from direct observation. So instead of saying patient seemed upset, you would write patient became tearful. That is something you can factually say. The patient seeming upset, while it is a fact to you, to the patient, they may not have been upset. So to them, it is not a fact. This is objective, can be proven information. Accurate, exact descriptions and measurements. We are not going to say patient seemed depressed. We're going to say patient PHQ-9 score 17, measurable and an exact description of what's going on. Complete. You have to include the who, what, when, where, why, and how, and it cannot be biased. Do not document, like I said, patient seemed upset. You want to document things like patient stated, quotes, and put exactly what the patient stated. Patient standing in corner of the room, fists balled. Anything that you can observe and prove factually. Do not put your opinions, your thoughts, what you read into the situation, anything like that in the documentation. It needs to be complete and factual. And then timely. Make sure when we're doing the care, we're documenting as we go. I don't like seeing that a nurse did not document anything they did from 7 a.m. until 7 p.m. That gives me no idea of how the day went. You need to be documenting as you go. If something happens, take the minute to chart it. If you don't have time to chart it in that minute, write it down with a time so that you can timestamp it to when it actually happened. Medical abbreviations, everybody's favorite. Best practice is don't use any if you're unsure. So there are some standard abbreviations. They're uniform. Everybody in the medical field knows, like things like ICU, MRI, BP, CPR. Those are generally acceptable abbreviations. However, there are a lot of abbreviations that can be dangerous if they're misinterpreted, misread, and they can cause errors that may even lead to death. So we need to avoid these. That is why I say it's best to just avoid abbreviations altogether. Do not say patient SOB, just say patient short of breath. It doesn't take that much time and it prevents any issues from occurring. Verbal prescriptions. In general, nurses should not be taking verbal prescriptions. The provider should be able to put them in the computer, especially with the advent of smartphones. Most providers have access to charting software through their smartphones. That being said, it's still very important that nurses know how to manage a verbal prescription safely. The first thing is that only the RN can accept a verbal prescription. So we are going to confirm. We're going to make sure it's okay in our facility. We're going to make sure we've got the right patient and we're going to document the prescription exactly how the provider says it. So if the patient says, or if the provider says, give morphine 2 milligrams every 4 hours as needed for 7 to 8 out of 10 pain, that is what we're documenting. Next, we're going to read it back to the doctor. Make sure we read back every single thing we wrote down for that patient to make sure the prescriber said it correctly and you heard it correctly. Any discrepancies? That's why we read it back. Then the provider can say, no, 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 what I meant to say was 1 milligram. And then after you correct it on your paper, you are going to again read them back out loud what you wrote down. I don't like seeing somebody who says, okay, he said 2, he meant 1, I crossed it off, I put one. No, we are again reading it back to the provider to make sure we got all the information correct this time. HIPAA. HIPAA protects the patient from other people knowing about their private health. The only time you can break HIPAA is if there is a danger to the patient or to someone in the public, and it needs to be an imminent threat. These are the patients in the psych units who say, I'm going to murder so and so. Or you're dealing with a patient, an outpatient, that says, I'm going to kill myself. Those are times that HIPAA is okay to break. It's also okay to break HIPAA if a child confesses to you that their parent assaulted them, or if an elderly person confesses that their child is financially abusing them. If there is imminent threat to somebody, you can break HIPAA. Otherwise, do not. And that means don't document about a patient on your personal Facebook. Don't take pictures in nursing homes because you never know who might be in the background. Just don't do it. It's not worth the risk. If you violate HIPAA, you can lose your license, a lot of money, and your freedom. The HITECH Act encouraged facilities to have computer or provider order entry systems, which is why nurses should not be taking verbal orders as often. This made it that the physicians have to put in the orders in the computer to minimize errors and enhance safety. So, if a physician calls and says, I want to give a verbal, it is okay to say, is there any way you can just put it in for the patient's safety? Key benefits: minimizes medication errors because it's going to compare what the provider is ordering to what the patient is on and what they're allergic to. It eliminates those errors because physicians have notoriously bad handwriting, inconsistent abbreviations. Uh, Magnesium sulfate and morphine have very similar abbreviations. Magnesium sulfate is MgSO4 and morphine is MSO4. So it eliminates that, and those are two of the do not use abbreviations. It activates alert systems, so if there is a potential issue, it's going to pop up and let the doctor know. It has clinical decision support systems to make sure we're dosing appropriately, and it allows for everything to be more quickly and efficiently sent to the right department.